So are we on? We can't tell.
Yes.
Oh, we're on. We're live. Well, welcome. We are hailing from Los Angeles at the University of California, Los Angeles. Welcome to the session on multi-level perceptions of the role of disclosure in conducting trauma-focused research, including community, clinical, and research perspectives. I am Michelle Cooley-Strickland. I'm pleased to be the moderator of this workshop roundtable, and we are supposed to be 4 presenters. We are missing one because consistent with our title, trauma, we have one of our presenters has lost a family member and was unable to come today. But we will try to represent Dr. Loeb as best we can. We are pleased to have on our panel Enrica Norwood-Scott and Dr. Gail Wyatt. Enrica Norwood-Scott is a research associate and graduate student at Pepperdine University. Let's hear it for, I don't remember what the mascot is, but yay for them. Thank you. Dr. Wyatt is a professor emeritus, and when you have your signature for your email, and some of us start off and it's just like a line, and then you graduate. So Dr. Wyatt's line underneath her signature is about this long, and I'm not joking. So we'd like each of you to introduce yourself. Also, we have live audience members who are going to introduce themselves as well. They're from the Sustained Academic Capacity Building for Excellence through Research and Training Program, our partners in South Africa. So we built in our own audience. We knew to expect about 25 people or so in the audience, and we are looking forward to your questions. So Enrica, when you introduce yourself, would you please address your experience with community?
Yes, my name is Enrica Norwood-Scott. I'm a research associate 3. My background is in trauma. I'm working with women and men with HIV, but previous to that, I was a retention and recruitment specialist working for Common Sense Media for their subsidiary that was basically working on a children's Bill of Rights. And during that time, that is where I learned how to retain and recruit community members, also with a focus on empathetic technique.
Thank you. And what's your biggest tip for retaining community members, would you say, for our participants?
I think the biggest tip would be authenticity and lived experience. Find the people who know the people, and I think you'll do well.
And is that any different, the advice when you're working with a trauma-focused population?
Yes, that's incredibly important as well. I think that, when you have individuals who have experienced or, walked, different paths alongside others who are experiencing different levels of trauma, it helps when someone is accustomed to what, an individual may be going through. It's important to have that level of understanding.
So that level of understanding, you mentioned lived experience. Is it possible to work with a population like this without having the same lived experience? When you say understanding, is it something you can learn in school? Is it something how can you learn it? Do you have to have personally experienced it in order to really connect?
I'm along the school of thought. Yes, in a perfect world, you would want people who have gone through the experiences of the people that you're trying to reach. That's important, but they're incredible individuals who are just empathetic. And if you have people who really care about the people that they're servicing, then I think that you'll have equal results as well.
Is there a way to assess the empathy, would you say? So it's the personal understanding of whether you've had that similar level of trauma, but you can't ask that during an interview per se. When you're we're talking about the research component, when you're trying to hire staff, how do you help understand whether those are the right people that you should have?
Well, I think that it's important to have recruitment specialists who are trained to recognize who the best people are for the job. Such as for me, I worked for the Obama team and they had recruitment specialists, and some of the questions they asked, well, tell me about your life. Tell me about your experiences. Well, what are your siblings doing now? And so they were able to garner and get a whole picture of who you were and some of the experiences that you may have gone through to make sure that you were a good fit for what they were trying to do and the people that they were trying to reach.
And are you referring to President Obama?
Yes, I am.
Okay.
Yes, I am.
Okay. Thank you. Thank you. Dr. Wyatt, please introduce yourself and tell our audience about yourself, and particularly related to the clinical arena.
Okay, so my name is Gail Wyatt. I am a licensed clinical psychologist and professor in the Department of Psychiatry in the David Geffen School of Medicine, and also director of the Center for Culture, Trauma, and Mental Health Disparities, which I think is our cornerstone for bringing all of us together and having the opportunity to work together and train other people together. I've been in the field for 50 years, and I think my experience in disclosure and some of the struggles that individuals have in disclosing, particularly if they're people of color, has come out of my clinical experience first. And also hiring individuals who would work on research projects gave me a very keen sensitivity to how difficult it is to find the right people in the right study, and how if you don't know the community and how certain events affect individuals, it would be really difficult to hire people, because you might hire them based on their resumes or their CVs, and that really has less to do with how human they are, how empathic they are, and how comforting they can be in a conversation when talking about difficult experiences like experience of trauma.
And you also mentioned about the hiring process and disclosure. Having done this work for half a century, you have weathered the changes in what's acceptable and what's not in terms of hiring and disclosure and being in rather invasive types questions. Enrica, you mentioned how it was more conversational, perhaps. Tell about your history, about your story, about your life, about your family. So you are navigating some interesting waters. Dr. White, you want to share with us some of the historical changes that you've seen that have evolved in terms of the hiring practices, and those that are beneficial and those that were not?
Well, first of all, I've been hiring for as long as I've been a professor. So it's in the day when we started, asking personal questions was very uncomfortable because people didn't talk about some of these experiences that we have to ask about now. And you couldn't ask, for instance, if you had an experience of trauma, unless you had a different way of discussing it. So what I did was to talk about my practice and the kind of people I saw when I was first getting my first grant. And that just generated a conversation around how people don't want to talk about certain topics in the community and how they're perceived as weak or ill or sick if they have these histories. So in many sort of middle class Westwood, UCLA settings, parties, if you talked about your therapist and what problems you had, people would all gravitate to you and share what their experiences were. In the Black community, people would move away from you in the feeling that there was something wrong with you. And I think that has changed tremendously. People didn't see therapists back in the day. Now I think people are looking quite actively for somebody who looks like them, who can be their therapist, so they can really select the kind of person they would be most comfortable with. And I'm really encouraged by that, overwhelmed by how many people want to see a Black female therapist, but also encouraged by the fact that if you have a good reputation in the community, which means you're not just in the community, you're also actively speaking, volunteering your time, doing anything you can and fundraisers to bring attention to the needs of people who don't have money for therapy. I think people perceive you as a person who cares. I was fortunate to grow up in a home where my parents taught in Compton and Watts their entire careers, and they taught high school. So
Can you describe what Compton and Watts are?
Compton
Because
and Watts
we're-
are two areas that are disproportionately affected by many health disparities and mental health disparities, and disproportionately affected by lack of access of mental health and health facilities that would be able to treat them appropriately. So it's an area that is in great need, even today with all the changes that we see, but also an area of great activism. A lot of our leaders in Los Angeles County and the state, in the nation and the world have come from areas where they also did not receive the kind of care that they needed, and yet grew up in homes that advocated for their speaking out, for their joining any opportunity they could to bring attention to the area and the fact that other areas had more opportunities than this one did. UCLA brought my attention to the disparities just by the fact that they once defined their catchment area, which means an area that they have to see in some kind of treatment, as West Los Angeles, which completely cut out the areas that we're talking about that have disproportionate needs. And of course, that didn't satisfy me. So all of the grants that I've received over the years have been in areas like Compton and Watts, where I grew up. My parents knew them. People still come up to me and talk about how my mother taught them English or my dad music. And so it's really warm, and it hasn't changed because I'm still involved in those communities. I haven't stopped. And I think that's the kind of visibility that people want to see, that you're not just visiting because you have a research project, but that you're visiting because you understand that in this huge city, there's a variation and we need to level it. And we can. We've done better. We need to do better. But there's a lot that we can do as professionals. And we've never stopped trying to encourage UCLA, which is now slowly beginning to change its image from one rather elite university to one that's really concerned about what happens in Los Angeles. That's progress.
And how do you change the image? Because some of our audience members might be from represent arenas where they have a particular image that they come from, either personally because you don't match from just a direct observation the community in which you're working, doing your great work, or that you come from a place that has a certain perception or image. And how do you work to build? I think you mentioned a few of the factors in terms of volunteering for providing services and being in the community. Enrica, do you want to speak about how one of our community partners serves and how we kind of worked with them, but build in disclosure? And I think also, Gil, you talked about a little bit about stigma when you talked about being providing therapy, that now you've seen a change. It's more acceptable.
In terms of the Oasis Clinic?
Yes.
Yes, the Oasis Clinic was founded by Wilbur Jordan. Wilbur Jordan was the first physician to find the first case of HIV in a cisgender population. For a year, he traveled around the country sounding the alarm, and he finally found the funding, and he built the Oasis Clinic and stayed there. It's right across the street from MLK Hospital in the middle of Willowbrook. Watts Willowbrook is connected, and it's also adjacent to Compton. And so that clinic was integral in the first beginning stages of the HIV epidemic. And Dr. Jordan was on the scene from the very beginning. The interesting part about this clinic is that when it first opened up, most of the patients would go and see Dr. J after 5. Some would even go in like after midnight because they did not want to be known or seen. And so in terms of our community,
being recognized as having HIV, and this is in the 80s.
This was in the
60s. What started in the 60s?
We had HIV in the sixties?
Mhm.
Well, in the 80s, the research began to really formalize,
Yeah.
but something was wrong and we knew it. People had
Yes.
health problems. It's been identified as an illness that was I guess, labeled as being found in UCLA, but in the Black community, there was something going on even during the Vietnam War and after, and we didn't know what it was. So it just gave us an opportunity by the 80s to be able to call attention to the fact that now it had a name, now people knew they needed to get tested. There was a lot more attention being given, but a tremendous amount of fear because we didn't know how long people would last. We didn't have the medication we have today, nothing near it. We didn't know what to tell women, particularly pregnant women, if their babies would live, if they would live. It became a death knell in the 80s when finally people started talking about it. But you have to remember that the presidential office was held by someone who wouldn't even say the word AIDS. So we've come a long way as a society, and an even longer way, I think, in communities of color to recognize that if you don't have healthcare, it's very difficult to identify your risk for transmitted diseases like HIV and AIDS. So the stigma was from the very beginning applied to communities that just didn't get care and had given up and not gone to the doctor. Then the effects of that stigma meant people didn't want to go, even when they had symptoms that were described as being similar to somebody with HIV and AIDS. So we've had a problem as long as we've known that possibly this could be AIDS.
Yeah.
Absolutely.
Go ahead, please add to that.
Absolutely. And I should say that, ACEs clinic was one of the very first clinics to open up and treat patients, and is still standing today.
And you have a story, Enrica. You have multiple stories of fond memories. Dr. Jordan passed in last year. Yeah.
In 2022,
Uh,
23,
Yeah.
23.
Yeah.
Yeah, I mean, just Dr. Wilbert Jordan, if you want to look him up, it just, his work is pioneering, and he devoted his life to the health and service of people with HIV/AIDS. So you have a story too about, you're trying to mind read me what story I want you to share about people who've gone through with the stigma. You have more than one story about the stigma and disclosure and how you help them to be comfortable in disclosing their status, as well as be receptive to receiving services, because part of it is in specializing your work with HIV/AIDS patients. You both are, I mean, Dr. Wyatt is, I remember the long name that I said, half of 3/4. It's a mix between HIV/AIDS and sex therapy and sexual health in terms of the work that she's done. But in terms of boots to the ground and working on the research projects, you're the person who has had the most recent experience on the day-to-day with the participants in our research studies. So sharing some of those stories about their own experiences with HIV/AIDS and disclosure and stigma.
Yeah, in terms of our participants, a lot of our participants have come into our groups, and many of them have disclosed to their friends or, of course, their providers. But most of them, I would say, have not disclosed to their entire families. They may have one or two people who may know that they're HIV positive, but overall, a lot of our participants have not disclosed. They still perceive that there is stigma within the community. And one particular participant stated, I have to deal with people having attitudes in the clinic. I don't want to have to deal with people having attitudes in the stores or at church or at the family reunion. He basically stated that, in terms of exposing himself, he called it exposing himself and stating that he was HIV positive would be kind of like an emotional roller coaster. He didn't know who to trust, and he wasn't so sure that other people would take that disclosure and disseminate it across the spectrum of his relationships. And so it was really important for him to understand that it was a choice that was truly his, but also understand that at least one person in his family that could, advocate on his behalf, just in case something happened, where he needed someone, if he was incapacitated. At least one person needed to know. And so he is currently trying to deconstruct and come to terms with how is he going to disclose and who will he disclose to. Sometimes, the stigma with HIV and almost any sexually transmitted infection is so ingrained that, fear and the possibility of rejection is so strong that most people are tending to keep their disclosures to themselves. And I feel like, I won't say it's a problem, I will say that it is an issue that really needs to be addressed. And I don't think the issue really lies with people who are living with HIV. I think that our society needs to be more open and more compassionate towards people and allow people to say, this is who I am, and this is where I'm at, and this is what I need, in a way that is, received on a level that is very accepting and also extremely pertinent to each individual.
And so if you could give 3 recommendations to help our audience really achieve that, what would you say?
I would say, first of all, know your people, know who to trust. We have a saying in our family, Uncle Chester cannot hold water. And so, individuals who are around you that can keep, what you share with them, secret, and you also know individuals who can handle, what you have to say. You just really have to know who you can trust and who you can go to, because it could, turn into a situation, in terms of one participant disclosed their status and they were bombarded with questions, not only by family, but also by friends. And so you really have to understand and know who you can tell and if you should tell and if the time is right.
And I think for that reason, the conclusion to all of this is that people need to develop a respect for their biological families, but also to create another family, people that love and accept them as they are. And I think that has really helped to bridge the gap between who can you tell that perhaps can't handle that information. Now, that has not changed over all the years. People are still very wary about being HIV positive and who's going to accept them for who they are. Can they meet and become romantic with everyone if everyone doesn't know? It's still an issue that I hear a lot about in therapy, and how to develop relationships that are honest, how to disclose one's status to a potential sexual partner and a potential romantic partner, and how to share the findings of testing, not just with themselves, but with their partner. And ask the partner to share with them. So everything is open and on the table and transparent. And that conversation sometimes needs to be done in the environment of a counselor or a therapist, so that any feelings and reluctance or fear can be dealt with right there at the beginning of deciding that they want to take the relationship further or that they don't. They have concerns.
So I'm don't fall asleep back there. We're going to pitch it to you all to each respond with the 2 buzzwords. There's 2 more important things to try to address in describing who you are and the work that you do, is how you would recommend to our audiences in promoting in doing disclosure, sharing about your own experiences and your perspectives, and stigma, how that impacts. You're each doing research, and you each have some kind of clinical history, at least community history. So memory, I'm staring at you, so please introduce yourself. We'll turn the
Good afternoon, everyone. So I'm Memory Muturiki, and I am a medical doctor at the University of Cape Town in South Africa, and studying for my PhD at a different university. So just to get to your questions about stigma. I think it's been quite enriching just listening to the contributions. In our clinical practice, because I work at the university, so we have young people, and because the ARVs and treatment is very effective these days, we have young people who have been born with HIV. And so it's a big thing for them to enter university for the first time. And it's a time of exploring and time of starting new relationships, and sometimes for the very first time. And the issue of disclosing that status to their potential partners is for us very big, and at most they are reluctant even to be on treatment or to stay on treatment if they were on treatment before they came to university. And for that, we struggle with adherence because of stigma. We struggle keeping them on treatment once they are there. We also struggle with them then actually sharing with a potential or an existing partner the status. And so it would be great to know what other interventions have been used for young people in that situation where they were born with, and they are actually struggling with the disclosure if there are any interventions. And on our side, health promotion does work, and maybe having advocacy around people who are openly, especially if they are celebrities or at high respected statuses in life, where young people can actually admire that they are coming out openly and saying they are living with HIV. So it becomes something that is just normalized in today's life. So I think that's my contribution thereof.
Excellent, excellent. Thank you, Memory. That's very practical and you know, and involving college student populations. And being a lot of times here in the US, we talk about the acquired immune deficiency, but it's if you're born with it, it's been your complete existence. And so what a difference that is. And to provide suggestions for our audience in terms of having celebrities or people who are looked up to provide an example and model the behavior that you would like, the self-disclosure, and certainly maintaining medications for those who've been through trauma, also sharing that and being publicly transparent about it, and showing that there are benefits if you get use the resources that are available. But first you have to recognize what you are experiencing and get to be able to ask for the help. So thank you. And did you all notice that she has an MD and she's going for a full-on PhD? She's writing her dissertation now, and very impressive. So thank you, Memory. We have a student who Angelique, can you see? I don't know. You got to scoot your chair. So hi, this is. Say
Angelina.
hi. Angelina is right there.
I'm an undergraduate student who is taking this course because it's an area of interest for me entering into graduate school. I've been really in awe of all of your work regarding the sexual health and the stigma surrounding it. And as we spoke last week, I think this is a very important topic when it comes to the type of language that we're using with people about sexual health. The types of names that we're calling it, the awareness that we're having surrounding this information, because it is so sensitive and it does bring a lot of intense emotions sometimes for people. So I just think the work that everyone's doing is really beautiful and beneficial. So thank you for having me.
Excellent, excellent.
Thank you.
Any recommendations as the I can safely say youngest in the group for self-disclosure promotion and stigma reduction that you would present?
I would say opening up a conversation surrounding sexual health disclosures is important. I think that these types of conversations are really lacking. We learn so much as we're growing up in our lives, but one thing that we don't really learn about is our sexual health. It's kept in this box of uncomfort, and so people become uncomfortable talking about it. So much of the language we use is like, are you clean? Are you like, no? And these are extremely hurtful terms.
Mhm.
So I think like moving forward, opening up a dialogue about the way that we promote the conversation around sexual health in young people as a part of lifelong health and not something that is taboo and can't be talked about.
Great, excellent,
point.
thank you, thank you. Aniki?
Good afternoon, everyone. I'm Aniki Mabusela from South Africa. I'm a PhD scholar and I'm a professional nurse working in renal unit. With our patients regarding the HIV, I have realized that most of them, they don't disclose and it causes them to have non-compliance to treatment. Because at home, you'll find that their partner or the daughter have to hide the medication and they can't really be reliable in terms of the time where they can take the tablet. And in our hospital, initially we used to have a certain unit separated from the big building where they cater for HIV patients. But then we realized that it's not working because it also forms another type of stigma. Like when people see you go that way, already they know that it means you are HIV positive. So the whole building, they've cancelled it and now they are inside the main building and they are just part of all the patients. So I think it's also important.
So that's a great point. Thank you, Aniki, about the structural barriers that create stigma, that help perpetuate stigma, and to consider how even on the structural level, the architectural level, how people are perceived. And so that's an excellent point. And your work in the renal function area is really excellent as well, because you see people who are multi-traumatized. They have multiple illnesses or diseases and things that compound each other. So the work that you're doing in prevention is really excellent. So thank you. You're welcome. Enrica, before we get to Pavel, would you like to share your story about how the Oasis Clinic had closed and what they made? They had everybody go. Do you remember it? That they had everybody go to sit in a separate section in the hospital. So after,
Yes.
yeah.
Okay, so just recently, due to the rain in California, the older building for the Oasis Clinic shut down and they moved the clinic over to the main hospital of MLK. And they noticed that there was less foot traffic in terms of patients showing up in person, simply because you had the Oasis Clinic and everyone knew it was an HIV clinic. And then you had an optometrist and you had a pediatrician and you had to walk past these certain offices just to get to the Oasis Clinic. And so that framework is still there. That office is still there, but they are having some difficulties at this time, ensuring that patients are coming in to see the doctor at a regular time. An interesting story is one of the nurses who was working with Dr. Jordan from the very beginning stated that she even felt stigmatized because everyone knew that it was the HIV clinic. And she remembered the days that she was called the AIDS nurse and Dr. Jordan was called the AIDS doctor, and how isolating that was.
Yeah. So lesson learned, don't think about how you're referring to a group, even though it's shorthand, it might not be the most beneficial, especially in the long-term way of referring to your clients. But thank you. Yeah, again, structural differences, how you design might even increase accessibility or decrease and add to loss of retention. So Pavel Arthur, would you like to introduce yourself and tell everyone?
Yes, thank you, Michelle. I am Chavo Fugubin from the University of Limpopo, and I'm also a PhD student. And I'm a licensed registered nurse whose research interest is in trauma and mental health. So reflecting back on our topic, I think the issue of stigma in HIV and AIDS is quite a complex one, to tell you the honest fact. I'm not sure if whether it is because of the fact that HIV is a sexual transmitted disease. The reason why I'm saying so is because, like, looking at my experience, I was working especially at a community clinic. So we normally struggle with, especially when a patient comes for consultation, especially with the sexual transmitted infections. We'll normally issue out a contact slip so that their partner can also come for treatment. But we normally struggle to get the partner coming up for treatment. So which, when I'm looking at it, because like I could also relate it to the issue of gender disparities, because we normally receive the female patients who are more compliant and are likely to disclose as compared to their male counterparts. So I'm not sure if whether it could be related to the issue of health seeking behavior amongst males, because they are likely not to disclose as compared to their female counterparts, which I should think if maybe other interventions could also be targeted on looking at the male partners where they can maybe get recruited so that they can participate and come up with the interventions that are maybe culturally appropriate to come up with or to get away with the issue of disclosure. Like, it's quite complex, like I initially said, the issue of stigma. HIV is still more stigmatized as compared to any other diseases at home. Like, even now, one of the interventions was for those patients who are virally suppressed, they don't get to go to the clinic. Like, as Aniki said, like, we normally used to have a separate buildings where they go and get treatment. And that what we get, we get rid of that because it promotes stigma. So it even now went beyond the issue of, like, if you are virally suppressed, then you get a medication to, like, maybe a private pharmacy. Yeah, a private pharmacy where nobody can recognize that you are going to fetch. Because if you go to the clinic on a monthly basis, that's where people will start to stigmatize, to say, why is this one? Because, like, you are still a youth, you don't seem to be having any all those old age, like communicable diseases like your hypertension and stuff. So people will probably assume it could be the issue of HIV and AIDS. So that's how one of the interventions that the government tried to come up with, so that people can go to their nearby malls, private pharmacies, where they can just go and fetch their ARVs, just to improve compliance and to also try to reduce the level of stigma amongst HIV and AIDS. So which it's still a challenge. I'm not sure if whether maybe other people can come up with other strategies that prove to be very much effective in terms of trying to reduce that. But for now, it's still quite a challenge. So that's my.
Thank you very much. Yeah, you both mentioned about medication and even how PrEP has changed from having a daily pill to pre-exposure prophylaxis as a preventative measure to reduce the likelihood of contracting HIV by over 90%. It's 90 something, upper 90s, if you use it in conjunction with a condom at 100% of the time. But to move it, because we had a research grant that you were the PI of, that was for women, and to try to increase the uptake of participation for African American women to use PrEP. And do you want to talk a little bit about that study, and then also both of you, and we'll come back to, you get a minute of reprieve for the rest of our scholars.
The study that you're referring to was funded by Gilead, and we were delighted that a pharmaceutical company that created these medications was interested in some of the barriers that communities of color are experiencing. We were limited by the fact that we could only recruit 50 women, and I think we could have recruited more had we had the funding, but it gave us an opportunity to look at some of the issues that some of the scholars had mentioned, as well as the ones that Enrica has talked about as well. And we were fortunate to have Enrica involved in that project at the Oasis Clinic. And generally what we found was that women were very interested in PrEP and PEP, but it needed not to be the only issue that they were being talked to. We also were concerned about reproductive health and the availability of STI testing and treatment in HIV clinics. And this is something that has been voiced over and over again in the community, that we need to have one-stop shopping when it comes to health issues, given that people are wary about them in the first place. And secondly, having to go all across town, and particularly in Los Angeles, is a major inconvenience and can help to discourage people. So that was an issue that we brought forward to Gilead, and they were very interested in the whole idea that they would, as powerful as they are, didn't realize that if they say to clinics, you have to have reproductive health services in your clinics for women, and you have to have STI treatment and testing and treatment for men and women, that those things could be something that could motivate people to come in. So we were delighted to have that opportunity, and we're still talking to them about the opportunity to do other studies as well. But it was a good signal that they were interested enough in the community issues and didn't see their continuing to promote sort of male-oriented models where we assume that everyone is excited about HIV and it's the only issue of their lives, that we would look at people in terms of their entire life, their entire health and mental health, and offer services relevant to all of it.
And I think that's a recommendation for our audience to really take away, is the whole person. Even though we specialize in specific disorders, so if we went around to each of us and identify what we specialize in, understanding that the individuals, our participants, our community members, the people that we treat, do not see themselves as segmented, do not see themselves as silos. And so the availabilities that we give must be consistent, because as we know, when we were doing the PrEP study, that they didn't want to just talk about HIV prevention. If anything, that was the least of what they wanted to talk about. Enrica, do you want to talk about the stigma and disclosure issue when we did the Women Prepping for PrEP 3? And may I say, we just had a paper accepted for publication on that, so we can maybe share that. I don't know if the folks with the conference can share that paper. And also, you referenced one of the papers that we just got published last week on sexual and reproductive health among diverse college students, which is addresses a variety of issues of maleness and the heteronormity, about how it's what's presented as the norm. We include pornography, which we talked about last week and in class. And when we talk about stigma, there are a lot of issues that are triggered when you deal with sexual and reproductive health in the mental health context. I'm a licensed clinical psychologist as well, and researcher, and started in the trauma space from specializing in anxiety disorders, and expanded and wanted to study PTSD and its impact on youth living in urban environments, and went from PTSD to and all types of anxiety disorders to more general trauma, and now work with the adult space in a variety of traumas, and am I doing sexual and reproductive health work to try to prevent the trauma of having some adverse outcome that perhaps could have been prevented in large measure, whether that's an unintended pregnancy or sexual violence or STI or HIV. And so there's a lot that can be done, which I think joins us together as a collective of all of you who are watching us now, and just caring about humans in a comprehensive sense. So now pitching it back to you, Enrica, if you can remember, you can just go ahead.
Yes, in terms of the women who joined the Women Prepping for PrEP Plus, as it was called, the biggest barrier was getting them not into the public health clinic. It was getting them to stay. The wait times were sometimes 2 to 3 hours, verified by myself. I would actually go in and sit with the women, and they were really afraid that someone was going to come in and assume that they had a sexually transmitted infection. And so that made it difficult to retain women in the study. And it also made it difficult to have the clinic buy in to ensuring that women could receive those services within OASIS, because I don't think until the women came in that they even perceived that there was an issue at public health in terms of the time frame to receive services. And also there was limited hours and days that you could go in, and it wasn't a really warm experience. It was very clinical. And so those are some of the things that we needed to address in a Women Prepping for PrEP study. And I think that the facilitators and myself, we basically had to walk hand in hand with the women into the clinic and sit with them to ensure them that, you know, they would be seen in a timely manner and that it was okay. No one would know why they were there. And certainly even if they did, it was something that they would be able to overcome.
Very good. You mentioned about the clinical or the dry environment, which is not welcoming, that makes people not want to stay. It makes it that they don't even want to come. So in part of in doing the work, and then you want them to disclose to you and be very honest about an area that is full of stigma. You need to set yourself up for success. So we use in our studies, use food. We use offer when the grant has the most money, there might be childcare, there's transportation, there is a sense of celebratoriness and a welcome. And that's, I think, in terms of choosing folks who work with our teams, is choosing people who convey that sense of you are valued. And so that's really important in the work that's done. So pitching it over, come on over. Can I get there?
Yeah, my name is Multilevel. I'm a PhD student and I work for Chile University of Technology as a data manager. So
As a determinator. What data
data
manager.
Analyst, I worked for medical search council as a data manager for 6 years. So I don't know much about HIV and topics around it, but working as a data manager for Medical Search Council, we had a study called Flagship, which was a randomized clinical trial type of study. So we had 3 months, 6 months follow-up. So the target was for people eligible with those who are HIV positive and who are with alcohol. So there were some screening questions so that we can see who's eligible and who's not. So as part of that, the clinics that the hospitals that we were targeting were 4 hospitals to recruit those people. So what we experienced when the field workers were out there is that majority of people, they knew where the field workers were, and they will try to dodge that. And just to agree with Aniki said that they will try to stay away from those people who are recruiting our field workers so that they are not seen as people who are HIV positive. So that was the main point outside there. So part of the study was to check the ARV adherence. If alcohol is not affecting them taking the ARVs. And as part of that, we were collecting also blood through drinking, I think it's called drinking. Yes, through that, and DBS, dried blood spot also, so that you can test the viral load, the level of the viral load. So what we saw there is that during the 3 months follow-up, some they will come back, and some they will even, especially men, they will even give their wives phones to save the wrong number. Yeah, because they felt like we were interfering with what they were already going through. Yeah, so it was a bit of a challenge.
Yeah.
It was a bit, because we were targeting the sample size that we're targeting was more than 600.
Wow.
We managed to get 623, but because we added 2 more hospitals, yeah, who didn't know much about us.
Yeah.
And people who ended up participating after 6 months, they were less than funded.
Uh,
So the level of retention or it was quite low because we thought all of them would come back for. So there was a intervention between. So 50% of the participants were chosen for intervention for motivational, which is motivating. So yeah, for motivate, we had some counselors who were going to meet to them to tell them to just to share with them how alcohol can affect their Ayurvedic intake. And, yeah, so when we analyzed the results, we realized that the level of alcohol, it was still high when you compare baseline and 3 months follow-up. It was 3 months follow-up was higher than even baseline.
Oh no!
But 6 months it became stable.
Okay.
Yeah.
Okay.
That's what-
Oh my!
Yes.
You don't want your results to. You don't want to show that your intervention made the problem go up.
Worse,
Yeah,
yes.
yeah.
So
Uh,
it was a bit of-
It's very. But excellent. Thank you for sharing that experience. And as someone who is a data manager, you're not the person like Enrica who would go and be recruiting and doing the intervention. You were just seeing the numbers and hoping that people would stay in the trial so you wouldn't lose your power to detect the differences. So, but very interesting. Again, another example of how the structure of the physical interactions and surroundings can add to people wanting to be involved or repel them so that they don't want to be involved. Enrica talks about how, again, Dr. Jordan would go, when you say he would be at midnight in his office, he would be available whenever people came, as opposed to usually in research experiences, we set up these very specific and even clinics, we set up these are the times that we're available. Well, people have children and they have jobs, or they don't want people to see them, or how are you going to make it very available? What's the one he worked out of his trunk of his car?
Yes, that was a story that many of his clients told, at his memorial. Dr. Jordan would show up at midnight with a briefcase, knocking on their door, and would go in and treat them and then leave. And he had one particular person who would be his kind of like his second hand. And he would call that person around 2 a.m. on the way home so he wouldn't fall asleep, because the capacity, and the cases were so great at that time. And he was one of the few doctors who was willing to treat people who were positive. And so
Yeah. Let's see. So it's so excellent. And I have to say, knowing you, Enrica, you have a Dr. Jordan approach. And I'm sure each of you here, because of your devotion, you included, is it's not the job, it's the person. And you don't lose a person, and whatever it is that they need is what you try to provide. And it kind of is coloring outside of the box in terms of when we do research that has strict protocols on how you're supposed to behave. Well, if someone has a very big need that's interfering with their ability to participate, do you ignore it? Do you want to give some examples of cases where you go? Okay.
Sure. SPA 6 is, where most of our research was taking place. And I call that SPA 6, the areas of South Central Los Angeles, Watts, Compton. I call it ground zero for every disparity that you can think of in this country. And so in this particular space, and the fact that, ACEs clinic is right across the street from Augustus Hawkins, we would get people who were just coming out of treatment, or basically going to see their therapist, but we wouldn't know until maybe the third or the fourth session that they had these type of issues going on. And so one particular day, I had a participant, and she came in and she said, "Oh, I was just released." And I looked down and she had a 3-month-old baby in a stroller, and she was experiencing symptomology. It seemed like she was talking to herself, but she was convinced that people were following her. Well, she was already out of the study, but every now and then people would come back to say hello, and it wasn't my job to send out referrals or anything else, but I felt like I had a duty to make sure that I, made the call, as heart-wrenching as it was, to make sure that they understood and knew that she wasn't okay. She shouldn't have been released, 2 days ago, if she's still experiencing it, especially if she had an infant in her care. And so those are the type of things that I've seen. I've also had, participants come in, and they had, one particular participant, she came in and she brought her partner so that I would know that she wasn't fabricating, but they had an infant in a stroller, and the infant had on a plastic, bag for a diaper. And so again,
grocery store plastic bag.
it was a grocery store plastic bag. It wasn't my responsibility to ensure, because again, I was basically the coordinator. I wasn't even the facilitator. But when you talk about empathetic research, you see people, you hear people, and you make sure that they're okay. And if they come into your study, you have a responsibility to ensure that while they're going through the study, if there are any issues, you address those issues and you hand them off to some other people that will do what they're supposed to do. There's a lot of money in the community, make no mistake about that, in 501c3s and people who are supposed to be doing the work. And there are people who are supposed to be, doing what I was doing for some of the participants, but there was like a lack of communication. And so it was up to me to make sure that the communication was ongoing, and I was able to hand these participants off to community organizations that were able to get them the support that they needed.
Excellent.
Excellent. And that commutes to retention. It commutes to, so when you're saying you have a 3-month follow-up or a 6-month follow-up, it is that someone cares deeply, that has people connect. You receive calls all the time because people know you care and you're resourced, and you bump it up. If it's not something that you're able to do, there are other people that who have resources. We come back and have team meetings, and you'd say, this person has this issue. What can we do for them? And sometimes the answer is we don't have the resources, but to feel like the participant, to feel that they are heard and cared for, even if you cannot provide the service that they actually need, but the fact that they feel comfortable disclosing what it is that they are struggling with, and that there is someone who's compassionate about it at the other end, that's really important.
And I'm sorry,
Yeah.
that's why it's so important to hire people with lived experience. I'm actually from the community. I grew up in the area of Watts, Willowbrook. And, when people are sitting before me, I see my cousin, I see my brother, I see my aunt, and so I treat them like they are family, because I understand that if it were not for different buffers in my life, different people who came along, I would have been sitting in that chair as well.
That's an excellent point. And Gail, in terms of hiring, being more flexible, when you're writing your grants and you have to write what the requirements are for certain minimum requirements are for positions, to have wiggle room in that, because sometimes people with lived experience necessarily might not have the credentials to make it, but what latitude should be in there. So you hire the best person who's going to serve that role, not necessarily the person with the most experience or the most degrees behind their name.
Right, and that's certainly true for people who have histories of incarceration or who've been homeless. And that's not a small proportion of people in communities of color.
Right.
That the principal investigator needs to go to bat, so to speak, for those individuals, describing to the university or the organization why they should take the risk and hire this person, and what they can contribute, because otherwise these are many times individuals who never get a second chance. And it's important that they be involved in research. They have access to the community and resources in the community that other people may never have. So I think we need to work very hard to make sure that professional, well-trained and culturally congruent principal investigators of color have an opportunity to do research in the area of trauma and stigma in particular. Some of the studies that are being conducted are interesting, but they really don't touch the kind of stigma that people of color have experienced all their lives. And you can't just study one type. You really have to look at the enormity of how a person feels about themselves and what makes them stand out and feel different, or maybe not as well accepted as someone else.
And that conveys to the participants feeling understood,
Mhm.
because we have a variety of types of assessments and interviews, and
Mhm.
if they feel like that they are, that these people get me, then they're more likely to be honest and disclose and be retained.
Mhm.
So are you falling asleep over there? Let's see. Okay, we can see you. Yeah.
Good afternoon, everyone. I'm Kutala Sipovana. I'm from South Africa. I'm a PhD candidate. For me, I've got three things, the experiences I have. Firstly, I went to the Human Science Research Council, where I was working with Professor Bai. He was a principal investigator. So we conducted the study amongst the people living with HIV, and one of the goal of the study was to promote disclosure amongst those the people. And the study we conducting in we have having baseline, and then we'll do the intervention where we'll teach about the disclosure skills, promoting disclosure, and then we'll do follow-up at 2 months to check if after the intervention there were any changes. Did they disclose to the family or to the immediate families? And then we go at 6 months disclosure. Sorry, 6 months follow-up to also check if there's any change. Fortunately or unfortunately, I did the study before it finished for another opportunity. Secondly, on my master's, I was investigating authenticity, that is prevention of mitochondrial transmission. In South Africa, the program started around 2004, but still there were children born HIV positive. So the study it was on 2015, between 2015 and 2014. So one of the key factors to check the authenticity program was because why there are still children that are born from being HIV positive, what the authenticity program is there. So one of the factors was that the disclosure, people were not disclosing, the mothers were not disclosing to their husbands, and also they were avoiding the disclosure, avoiding the stigma, and they were not taking their treatment completely, like they will take or default because they will avoid to take in front of their families. So the recommendation of the study was to the spousal support or partner support to be involved, and also the early booking of the antenatal visits so that they could find their status early. Thirdly, I went at the Waters University as a health promotion practitioner for about 5 years. So I was one of the key performance areas was to also do HIV testing and counseling. So the students would come to the clinic to do the test, and they would be HIV, the result would be HIV positive some. And I will refer them to professional nurses for initiation of ART. They will be given the ART, but they will default because some will find that they are sharing with their roommates, so they are unable to take their treatment, and also they will avoid being stigmatized. And one of the interventions as a health promotion practitioner was to organize HIV testing, organize talks, And also there is a peer education program where we would train other students as peers so that they would talk peer to peer. So that's my experience.
Wow, well, thank you. That's a really phenomenal experience and thank you for your service in so many ways. And you learn as you go. You learn as you go and that's the nice thing about doing research is that you build and keep improving. So those lessons that you learn, sometimes hard learned lessons can be applied and improved for the next iteration. So thank you so much.
I'm Anita Hussain. I am an occupational therapist at Stellenbosch University in South Africa and also a PhD candidate. So I think I also wanted to share three lessons. One of them is my field of experience is in work rehabilitation. And so thinking about the issue of disability and disclosure around acquired disability in the workplace is something that we often have to deal with. The person who sustains an injury or illness or disability is not always willing to disclose to the employer that they now are struggling with their work and they need to be accommodated, even though legally they are, obliged to be, the employer is obliged to accommodate them. And so a big part of the job is actually counseling those people, but thinking about the real consequences of talking to your employer about potentially not, struggling with certain aspects of your job. And, unemployment is very high in South Africa. So looking at how is this going to either positively or negatively impact you potentially, and what would be the best option for you around how to disclose, where to disclose, whether or not to disclose. So that's around disability. And then my PhD research is around pain and mental health with garment workers. So we work in workplaces which addresses that issue of the stigma of the clinic and workers not wanting to come to the clinic for treatment, but also struggling to take time out of work to the clinic, which, let's face it, is usually open during work hours. When do you go for healthcare if you're a working person and if you're on minimum wage? And you're actually going to get a deduction in your pay if you're taking time off work to access healthcare. So what we do is we actually go and treat those individuals within the workplaces. When someone gets referred to for work rehabilitation, we go to the workplace, we request a private room, whether it's a boardroom, sometimes it's a manager's office, and then we consult with that individual and also then make ergonomic modifications of that sort of thing on the work floor. So that you're taking treatment to where people are, which is really valuable. And you also end up in catching disability and injury very early if you're taking treatment to where people are. Then the issue of stigma around mental health has been a big concern in my experience and in my research. And so I've chosen to address that by linking pain with mental health, because often we know that pain and mental health are very strongly related. When one has chronic pain, there's a higher risk of mental illness. When you have mental illness, there's a higher risk of chronic pain. So if we treat both, people may be more willing to come for pain treatment and receive mental health treatment at the same time. And so that's how I'm trying to address it in my study, and hopefully we'll report back in a few years and let you know how that works.
Thank you, Anira. Thank you. Excellent, excellent. You guys, how beautiful are they to have the contributions? So we have time for just your last thoughts, Enrica, and then Gail, and then we'll wrap up.
My last thought is that, in terms of HIV infection, sexually transmitted infections, we need to reframe the word and perhaps start labeling it as something else. And my proposal is to start labeling it as intimacy-related infections. Everyone needs intimacy. We can all agree. And whether or not you feel that people should be having sex, we can all agree that everyone deserves to have intimacy. And so I think that if we reframe the word in such a way, perhaps, society will, move in the direction of being more compassionate to people who are diagnosed with HIV.
Very good, thank you. And you've already copyrighted the term.
It's just copyrighted now.
Okay, Dr. White, Gail?
Well, I'd like to end the panel, which has, I think, been very, very informative, hopefully, and instructive to all of us, with a call that I think in communities of color, we really need to be more insistent. We need to demand that attention be given to issues like trauma and and stigma. They are huge, and we're not making the progress that we need to make. We're not changing research designs or who gets an opportunity to do the work. And I think that if we don't demand that these issues take priority, we'll simply continue to be studying how to take the medicine. And that is not the issue. The issue is how to make people more comfortable with their own health and mental health, and how to help them to feel better so that they will want to take the medicine. And if we don't get that piece addressed, different methods of taking medicine is an interesting exercise, but we need to focus on people. People of color are the most disproportionately affected by HIV and AIDS, and yet the research is not addressing what we need to do. So I hope that the panel has inspired everyone to get angry, get fed up with what we've been doing. Business as usual is not accepted from this point on.
And what's not accepted from this point on is our time. So with that, we want to thank you all and thank for our guests and thank you for the opportunity to be here at the International Stigma Convention Conference. It's been a pleasure. I was told that we can upload some article sharing on the WHOVA site. So whoever has mastered accessing the WHOVA site among our team will be uploading those couple of articles that I mentioned. But thank you again for participating. And oh, good. Yay, we're getting some positives. Yay, guys.
Yay.
All right. Thank you. Bye-bye. That's really nice. Thank you, Patty and Francis and Bev and thank you
And
you all. And I
thank
trans,
you.
yes, I know.
That's the way it should be.
Okay, thanks. Bye.